30, so we can kick things off. Welcome to the July Valleywise Grand Rounds. And as every month, remember, please place yourself on mute, and we'll be putting the CME code in the chat starting about midway through. Remember, the CME code is through Creighton, so if you're texting, you do need to type the word attend before the number. I will be keeping an eye on the chat throughout and voicing it, or you can unmute yourself and ask as we go along. Now, this morning we are welcoming Dr. Nielsen, one of our child and adolescent psychiatrists here at Valleywise. Dr. Nielsen has stayed here in the Valley for his education and training. After Midwestern, he joined the Creighton University of Arizona Health Education Alliance for his psychiatry residency, and then stayed for the Child and Adolescent Psychiatry Fellowship. After graduating, he joined the DMG team, and today we are very excited to have him join us to discuss sleep, which is a topic that many of us work with on a very regular basis. With that, I'll hand it off to Dr. Nielsen.
Hi, everyone. Thanks for having me. Let me see if I can get it started. Can you see just the slides?
Yes, we can. But it's not on presentation view. I see the side slides as well.
Oh, you see like the notes and stuff?
Yes.
Oh, that's a bummer. I don't know. Let's see. Is it better now?
I would share the screen.
Oh, sorry. I apologize.
And then the lower.
How about now? Is that good?
Now that's in presentation mode. Looks good.
Okay. Can you see just the slides? Can you see it okay now? All right, I'm gonna get started. All right, so sorry about that. My name is Dr. Nielsen. I have no financial disclosures, and so today we'll be talking about sleep. I do want to give a little plug. One of the other roles that I do is I am a consult psychiatrist for the Arizona Pediatric Psychiatry Access Line. This is a free service for any provider in the state. You can call this line either between 12:30 and 4:30, and I can help run through psychiatric cases with you and help meet the need, and if you're wanting to treat or get access to for that patient. Today we're going to be reviewing some of the neuroanatomical physiological basis for sleep, the prevalence, and how do we distinguish between sleep problems and using the various treatments, whether it's non-pharmacological, behavioral, or pharmacological strategies. And so when we first start talking about sleep, there's the question of, well, why do we sleep? And generally, the consensus is that there is this two-process model. We have something called process S and process C. Process S we call like our sleep drive, whereas process C is our circadian rhythm. The process S is kind of how I remember it, and this is something that I actually talk a lot to kids, particularly a little bit when they're older. I might not use some of this fancy language, but you think that a lot of our teenagers especially have taken a biology course. They maybe have heard something about ATP. They know that that's energy. Well, when that energy gets used up, adenosine is a byproduct. And essentially, the adenosine in our body is what tells us to be sleepy, that we've used up energy. Specifically, the hypothalamus is what is going to be sensing that. And so, as we stay awake, that adenosine is going to build up, and that creates this sleep pressure. And then as soon as we fall asleep, it drops. But as you can see, if you don't fall asleep, that pressure is going to keep building up, building up, building up. And I find kind of showing something like this or drawing this has actually been helpful to kind of educate some kids about the process. The next one is process C, our circadian rhythm. And I have a picture here of some of the neuroanatomy on how light is impacting our circadian rhythm. And so our retina specifically picks up the blue light, which is what we see in the sky, and that's basically telling us that it's daytime. And so as soon as it starts getting dark at night, we are no longer having the blue light, and so that's going to tell our body to start releasing melatonin. But we now live in an era where that we are constantly seeing blue light all throughout the day. Especially at night, looking at our phones, looking at our screens. So that really disrupts our melatonin production. As you can see, there's quite a few different things that can interfere with our sleep. Perhaps it's waking up early for today's CME. It could be work, stress related to school, alcohol, tobacco, caffeine, recreational drugs, medical illnesses, chronic illnesses, pain, asthma, other things like that. Like I said, inconsistency in bedtime can be another thing. Not having that routine. Another thing that is kind of important to consider: what is that sleep environment that the person is in? Is there animals? Do they have a partner? Do they share a bed with a sibling or another family member? What kind of behaviors are you doing in bed? Are you reading? Are you watching TV, playing video games, doing homework, eating? And then last is our psychiatric illnesses. And when we talk about psychiatric illness and sleep, we kind of have this bi-directional relationship. Is it that we have sleep disruption first, or do we have mental illness that leads to sleep disruption? And when you kind of look at the literature, the answer to that question is yes. It's kind of hard to have one without the other. So when we talk a little bit about this, as Dr. Maurice was saying, when we talk about the general population insomnia, and this is just us talking about sleep difficulty, it's about 10 to 30% of the pediatric population is having issues. But then if we self-select to include more of our psychiatric illnesses, our neurodevelopmental delays, and chronic medical conditions, that can go all the way up to 80%. So we're likely going to be seeing and encountering quite a bit of insomnia in our clinics. When we talk about insomnia, so specifically insomnia from the DSM perspective, I kind of remember it as the rule of threes. And so this is typically, one of the things that you have all probably encountered, that people complain a lot about their sleep, but then when you ask them about it, it's very kind of like vague. It's like, oh, I maybe don't sleep. I just maybe didn't sleep last night. That's why I didn't think of it. So when we look at it from like more of a criteria perspective, I kind of use the rule of threes. So it's 3 nights a week for at least 3 months. And then there's 3 different things that can take place. It's either difficulty falling asleep, which is the most common, difficulty staying asleep or waking up, and then early morning wakenings. And then with all psychiatric illness, you have to have, basically, this is our criterion B, that this is causing clinically significant distress or impairment. Generally in our kids, it's going to be school. And so when we look at like those 3 symptoms of insomnia, it's about 72% have difficulty falling asleep. So that's the most common one. When I first read this study, I was actually surprised that the second most common was our early morning awakenings, and then followed by difficulty maintaining our sleep. And then if you look at this Venn diagram here, it's almost 20% have all three, have a combination of all three, which is quite significant. And then now when we look a little bit more at insomnia symptoms and comorbid mental health conditions, I really just want to turn you to these two columns up here. We have a column of no insomnia symptoms, and then we have a column of insomnia symptoms. And I think the takeaway is that for any mental health disorder, we have our odds ratio of 27.4, but then having any of those insomnia, it becomes almost double at 55.9. So again, quite significant. And as you can see, that when you have insomnia, most of the disturbances double, if not triple. And then these pictures here from this article also kind of show that the more symptoms you have, it tends to be longer in duration. So the idea being that the longer that you have insomnia symptoms, the more likely that it's going to cause psychiatric illness and or vice versa. So when we review normal sleep cycle in children, there's a few things that I think are kind of important for us to know. We have our different levels of sleep. We have our REM, which is most commonly where we dream, or we're having some of that kind of like bizarre or kind of like fantasy type dreams. Whereas then we have our now N1, 2, and 3. N1 and 3 being our slow wave sleep, and that being what is the most restful. And so when we talk a little bit about parasomnias, it's kind of important to know this, but our N3 is pretty much consolidated, our restful sleep, at the beginning of the night. Whereas our REM sleep tends to cluster more towards the end of our night. So that's why it's most likely when people are waking up in the morning, they're remembering their dream, it's likely that they're waking up during one of these REM cycles here. The other thing that I want to point out is notice that these peaks here at the top show that people have multiple wakenings at night. So even in a normal sleep cycle, it is very common and expected that we wake up multiple times. I'm not going to go through all of this, but this is the sleep requirements by the American Academy of Sleep Medicine for kids. And as you can see, it pretty much changes quite a bit by age group. Kind of how I remember it in brief, everyone needs kind of on average somewhere around 10 to 12 hours, where our infants are needing significantly more than that. But that's kind of like, I think, the general guesstimate that one can use to know. And notice that our teenagers, I'll say, this is where we probably get a lot of these sleep concerns. It's 8 to 10 hours of sleep. So this is my kind of like approach to pediatric insomnia. And for those of you that ever have kind of talked to me even on the call line, this is pretty much how I like to formulate most of any case that I work on. It's one, starting with the screening and assessment. Two, what are the behavioral interventions or therapy that we can do? And then last but not least is the pharmacological intervention. So when we talk about the sleep evaluation, it's important to look at quite a few things. We'll talk a little bit about exactly what we want to do for sleep history, but we want to know, is there medical conditions that are contributing? Is there concern for sleep apnea? Is there restless leg? Um, is there a neurodevelopmental history? Chronic insomnia is very common in ASD and ADHD. Is there any substance use, or is there any like supplement use? Are they drinking caffeine? Are last is kind of getting more. Is there a family history of sleep terrors, anuresis, bedwetting? Are these things common? Is it something that is predictable and expected? So a lot of times getting that history from family can be really important. The psychosocial history, that would include things like the environment that they're living in. Are they living in two households? Do they sleep better at one parent's house versus another? Are they sharing bed with another sibling? All of those things are really, really important. And then last is kind of getting more into that psychiatric history. Is there a component or a comorbidity that is contributing to the sleep impairment? And then last is the caregiver role. Is the parent involved in their sleep? Is there something that the parent is doing that is perhaps contributing to this situation of poor sleep? Are they having difficulty enforcing some of these things? Are they, is there other behaviors that the parent is doing to survive getting their child to get to sleep, but it's also not conducive in the long term for sleep. So when we talk specifically about sleep, these are some of the things that we want to know. When is bedtime? How long does it take for them to fall asleep? So that's what we call our sleep latency. How often are they waking up throughout the night? How long then are you staying awake if you're waking up? So again, kind of going back to that, some of that might be normal, that you might wake up a few times during the night, but you're able to fall back to sleep, and it's not that impairing. It's important to know, what time do we wake up? Are you laying in bed when you wake up? Are you hitting the snooze to the alarm multiple times, trying to get that, one more minute of sleep? When is the actual time that you get out of bed? Do they take any daytime naps? Is that common? And then last, do they have any of the kind of more of the things that would be more concerning for like sleep apnea, excessive daytime sleepiness, fatigue, snoring, any of those type of things? And so again, I can't highlight this enough. When we talk about sleep, sleep really is a behavior, meaning that it can be trained and it is a habit, so it can be habituated. So really, it's important to understand more about like the bedtime routine, what's going on leading up to bed. Um, is there a period of calming down, or are you watching TV, playing video games, and then turn it off, and then all of a sudden you're still thinking about the video games or TV show that you're watching? Particularly here in Arizona, what is the room temperature? Is it really hot in the room? We know that optimal sleep temperature is somewhere around 76 degrees Fahrenheit. Um, Again, people in the room, pets in the room, how dark is the room? Are they laying on their back, their stomach, their side? What other activities are they doing in bed? So these are things to kind of ask the parents, because a lot of times like the kids won't be knowing this. Is there any snoring? Is there pauses in their breathing? Unusual behaviors. So this is kind of getting into more of those parasomnias. Is there sleepwalking, sleep talking? Are they having nightmares? Are they having sleep terrors? Are they waking up, head banging? Um, all of those things. Is there this tendency to fall asleep unintentionally during the day, or they need to take naps? This is something that I feel like I see quite a bit. Is kind of more of the cognitive or behavioral disturbances. I get parents saying like, I can really tell when my kid doesn't get a good night's sleep because they're really irritable or cranky that day, or they're just not able to do well on a test or in school, so it affects their performance. And so sometimes, particularly, I feel like when we're doing evaluations for ADHD, it's really important to ask about sleep history to see if there's sleep things that are contributing to the poor attention. This is a screening tool that I recommend called the Bear screening. It's actually been validated in a pediatric residence continuity clinic that was almost 20 years ago when this was first came out, and it has been used quite readily since then. And it's really just these 5 questions. We're looking at, bedtime problems, excessive daytime sleepiness, awakenings, regularity, and then sleep disordered breathing. And the questions are by different age groups, as you can see here. Um, and basically, a positive score in any one of these more or less gives you more reasoning to kind of further evaluate their sleep. And then there's also some what we call like sleep hygiene screenings, and we'll get a little bit more into proper sleep hygiene in a second. But there is 2 different sleep hygiene scales, as you can see, one for children and one for adolescents. And again, I find these sometimes to be helpful for families just to kind of start thinking about, oh, is there things that we could be doing differently? And then last is kind of this sleep diary tool. Is really trying to get a parent or the child to fill this out so you can really get an idea, because kind of like I had mentioned, it can be quite people can be quite vague about their sleep and not really knowing. This is kind of a way to a little bit more actionable way of kind of getting an understanding of what is actually going on with their sleep. So now when we talk about sleep hygiene, so this is like the things that we can kind of encourage our patients to really be doing. And again, I think consistency really is the name of the game here. Um, Even if it's the summer, even if it's the weekend, trying to have a consistent bedtime, particularly for our young kids and adolescents, is important. Obviously there it might be social things that are happening, particularly for our like adolescents. But again, really encouraging that consistency can be the best thing for sleep. One of the other kind of recommendations for sleep hygiene is really using the bed only for sleep. Again, we are creatures of habit. Where it's sleep is a behavior, so we are any type of thing that we are doing in the bed that is associated with wakefulness, whether it's eating, whether it's playing video games, watching TV, that tricks the mind into thinking that the bed is a place to do fun activities. So when it's time to lay down, we're already been kind of habituated into thinking, oh, this is something that is for fun. I should be thinking about fun things right now instead of trying to sleep. This picture here is a picture of an iPhone. If you can go into settings, and most phones nowadays have some kind of night shift mode, and essentially, as you can see, this more orange tint on the phone itself is to filter out the blue light. And so this is shown to be effective in actually helping us regulate our circadian rhythm and have the naturally occurring melatonin. Some other kind of sleep hygienes, again, avoiding naps, avoiding caffeine, 6 hours before bedtime, alcohol, drugs, tobacco, all of those can impact our sleep. Making sure that we have a cool temperature to fall asleep, and then exercise. This is somewhat controversial, but it's generally not recommended within 4 hours of bedtime. I do. This is a whole topic in and of itself, but this is a pretty decent systematic review. But notice it's from 2016, so that's almost 10 years ago. But the evidence showed strong and consistent evidence with association with having either access to a screen or having the screen in their room. And it was associated with reduced sleep quantity, not so the number of hours, reduced sleep quality, so how good or restful that sleep was, and then increased daytime sleepiness. And so one of the other findings here that I thought was pretty interesting, children who had access, but even though they did not use, also showed that they had inadequate sleep quantity, quality, and daytime sleepiness. And so again, this was like almost 10 years ago. And we know that our social media use, our tablet use has increased since then. So a lot of times what I really try to do and encourage families is to get the devices out of the room. So again, just kind of putting a brief plug for this, you can go to American Academy of Pediatrics. They have a really good, I would say, some media use plan or social media use, or even like digital literacy that families can kind of get more educated on like the impacts of technology and how it impacts sleep. And so that kind of brings us to the next point, is like kind of that parent education of behavioral principles. So, you know, a lot of times parents' behaviors are going to model that for their kids. So if parents are having issues with their sleep and they're having issues, say, with like a tablet, or they aren't doing some of those things, then it's likely that their kids will also have difficulty. So other kind of things might be that their parents may not have like able to have limit setting. So the other day I had a family where the child was staying up, and this is like a young child, like around 8 or 9, was staying up till like 4 a.m. And that is not conducive to anyone's sleep. And they're having, you know, behavioral issues and whatnot. But then I asked something, you know, and he doesn't want to get off on his phone or his tablet or the video games that he's playing. And it's like, this isn't something that we can be solved in a simple, let's get it out of the room. I think that's probably the first place to start. But what we ended up doing was referring to therapy, because there seems to be that there's more of a pervasive pattern of difficulty kind of parenting some of these behaviors that also coincide with sleep. So when we talk about the primary treatment for insomnia, and this is true for adults, this is true for kids as well, the gold standard is cognitive behavioral therapy for insomnia. That's the gold standard of care. There is maybe a little bit less evidence in kids than there is in adults, just due to there being less randomized control trials. But this is the most important thing for sleep. And so this is usually where, again, you know, where I start for treating sleep is a referral for therapy. So I know CBT is something that we've probably heard multiple times. It's a little bit more specific when it's targeted towards insomnia. But there's kind of these 5 tenets that make up, which is the sleep education. So kind of educating basically what we've been talking about so far about why we sleep. Sleep hygiene. So what are the routines that are involved with promoting sleep? Something called stimulus control. And so that's, again, kind of a set of instructions designed to reassociate bed with sleep. And so that's kind of what I was saying a little bit earlier, of that we don't want to associate the bed with anything other than falling asleep. So having any type of awake behaviors in bed are not recommended. And that can be a really difficult thing to convince families to do, or convince family or kids to do, because they have been sleeping their whole life and this has never been a problem. But it can be one of the most important aspects of this. And I bring this up because I do think this is something that we can actually have discussions in part of our sleep education, of breaking that that the poor kind of like habits that get developed around sleep. With that, then we get more into the true cognitive behavioral therapy, which is challenging like thoughts that are providing kind of like anxiety. And sometimes this is like the example that I give, and I think this is probably relatable to all of us as physicians. It's, you know, we maybe wake up, get a page or something at like 4 a.m. and we look at it and we're like, oh no, it's 4 a.m. I need to be at the hospital in like 4 hours. So all of a sudden we're starting to do math, and then we're thinking, oh no, I'm not going to have enough energy to get through the day. And so all of a sudden we're starting to kind of spiral and have a lot of these like anxious thoughts. So the cognitive behavioral therapy has really helped to target those type of thoughts, those type of experiences, and help us reframe or shift away from those misconceptions. Kind of like with that, I think having our phone or like a clock out of the bedroom can be helpful, just so we're not tempted to start doing math so early in the morning, which can again get us all worked up from like anxiety or anger or frustration or whatever. And then last being our relaxation training. So these might be different type of like breathing exercises, things like progressive muscle relaxation, different things that can help calm or that are calming and relaxing. So now kind of moving forward. So like I said, now we're getting into medications. And so this is like, again, something to try some of those behavioral interventions first, because that's, like I said, what we have the most evidence for. So general principles for treating sleep, I always recommend combining it with a behavioral plan, which is everything that we just talked about so far, if we're going to prescribe medication. That being that the medication is almost like a little bit of a band-aid in this problem, but they still is having a gaping wound because they're doing all of these behaviors that are not conducive to falling asleep. You know, it's not uncommon that you might be hearing people like, I drank an energy drink at 9 o'clock, but I can't fall asleep by like 11 o'clock. Well, it's because you just drank a lot of caffeine, you know. So some of that education can be really, really important. So, but sometimes they might be asking for a sleep medication to help them fall asleep. So again, I think this having that behavioral plan also helps set expectations. So again, they might think that I need to lay down immediately, fall asleep as soon as I lay down or in the first 5 minutes, sleep 10 hours, and then wake up. And then that's just not realistic. That's just not how we or prescribing any other medication screen or substance use screen. It's also important to review what type of medications or over-the-counter medications that they've tried, supplements. So have they tried melatonin? Have they tried Benadryl? Or any other of the various sleep aids that are sold over the counter. And again, setting those realistic, clearly defined and measurable outcomes to come up with sleep. So it's like, if you have 5 awakenings during the night, maybe we're trying to get to like 2 awakenings a night. Something that's a little bit more realistic, as opposed to saying no awakenings at night. So kind of having more of that kind of graduated experience. The other kind of thing is getting both the patient and the caregiver to agree on what the plan is or what the goals are. So sometimes that can be navigating a little bit of that difference of opinion. The last kind of thing that I would say in general principles about medication is upfront coming up with a discontinuation plan. So how long are we going to try this for? How long are we going to be on this for? Generally, what I would recommend is we kind of reevaluate after like 6 months. But we really don't want people to be kind of chronically on these medications and depending on it for sleep. And so again, that's kind of why we go back to making sure that we have that behavioral plan in place, that we're actually trying to do those other things that will help promote good restful sleep without the need of medication. So generally, when we talk about the selection of medications, we generally go by the evidence, and then safety profile, and then the clinical situation. And then reviewing, is there any other psychiatric medications or any other medications that they're taking that there may be a drug-to-drug interaction with. So it's important to talk a little bit about timing of dose. So timing it, typically will be before sleep, 30 minutes to an hour before. And then the other thing is, do they have enough time for sleep? So it's like, if they have to be up in 4 hours, that might not be a good time to take a sleep medication, because they'll probably be groggy in the morning when they need to wake up. There's also the discussion of either it being scheduled versus being used, PRN. And then maybe they need to have a middle of the night dose. What is the maximum dosage? Then in general, in psychiatry, when we're talking about psychotropic medications, we kind of have this adage: start low, go slow. So starting on like the lowest possible dose before escalating up. So again, this is why I talk so much about therapy leading up to this, is when we talk about the FDA recommendations for insomnia for children, we don't have any. We don't have anything that's approved for insomnia. So everything's technically being used off-label. You maybe know that it works for adults. So that's why we use it in kids. Generally speaking, we have melatonin, and I will say that the order of the medications that I'm talking about is generally what we kind of consider the safest to least safe. So melatonin, like we had kind of talked about, it's a naturally occurring hormone in our body that is sensitive to the blue light, and this is what is regulating our circadian rhythm. Typically, it takes about 30 minutes to an hour for it to be eliminated. And when we are talking about the actual like physiological range, you can see that it's quite low. So it's 0.1 to 0.3 milligrams. And we usually, when we dose this, we dose it at about 10 times that amount, at the very least, if not more. When we talk about melatonin, it actually targets two different receptors, that melatonin 1 and melatonin 2. Basically, 2 is what is getting activated from a physiological range, but when we have when we use it as a supplement, we actually end up targeting more of the hypnotic range. Again, likely the reason melatonin is used, it has general acceptability from most providers. There's a high level of awareness, and there's been quite a few randomized controlled trials that show that it reduces sleep onset by about 30 minutes, which is quite significant. So then, generally speaking, when I start with melatonin, particularly for our kids, like children under the age of 12, starting at 1 milligram, and then our max dose is about 3, whereas our maximum dose for adolescents and adults is 10 milligrams. I'll be honest, I have never gone that high in an outpatient setting. This is something that maybe I've used in an inpatient setting or like on the floor on a consult service. But generally, I haven't gone that high. I on the outpatient setting maybe go to 6 milligrams. And then again, kind of in that treatment. So this is again kind of setting the expectations. We'll treat for using this for about a month, and then reassess how's it working, and then I would reevaluate. Can we discontinue it after 6 months? Some other authors say at a year, but again, I think it's something that needs to be reassessed a little bit more frequently, so we don't get in these situations where people are consistently on medications for sleep for a very long time, and they've never tried anything from like a behavioral or a therapy standpoint. So moving on, we also have Remeltian, which is the synthetic melatonin. And again, we don't really have too much information about this, particularly in our kids, though we do know that it has been shown to decrease sleep onset initiation. So again, we have that primary concern. Typically, the dosage for Remeltion is about 8 milligrams per day. Generally, it is well tolerated. Overdose effects are quite minimal. Overall, it maybe helps with sleep changes. However, it doesn't appear to impact sleep architecture, which is not, which is kind of a neutral thing, I would say. A lot of times in our insomnia, I didn't really talk too much about this. We want to get healthy sleep architecture. Some of the medications that we do prescribe do impact sleep architecture in a negative way, which basically means that it's less restful sleep. So both melatonin and Remeltion do not have any impact on the sleep architecture. Moving forward, we have diphenhydramine, which are Benadryl. So this is widely over the counter. It is it binds to it's an antihistamine, so that's just say antagonist, not agonist. But it decreases sleep onset initiation. Generally, it lasts about 4 to 6 hours, and it does have drug interactions with alcohol and other CNS depressants. So that's kind of like another consideration. There's like a few other ones. You may see hydroxyzine. So hydroxyzine is a little bit newer of a medication. Basically, the bigger difference between diphenhydramine and hydroxyzine is less anticholinergic. But otherwise, the dosage and the effects tend to be the same. I also don't have it on here. Another common sleep aid that is also used in the antihistamine class is doxalamine, or sometimes called Unisom, but that's used at a much lower dose. Again, we don't have much information about Unisom in sleep for kids, so it's generally preferred to use diphenhydramine. So typically our dosage is about 25 milligrams to 100 milligrams, but that's in adults. And so with kids, we probably want to start a much lower dose than that, at like 12.5 and maybe maximum being 50 milligrams. Another kind of thing to consider, there's multiple formulations, capsules, syrups. It is something that you can use as an injection or IM. I will say that there is paradoxical excitation. So this is something that's particularly important to be aware of, particularly in our neurodevelopmental population, such as ASD, that you might actually have excitation using diphenhydramine. And so that might be something to consider. So sometimes asking like parents, particularly in our neurodevelopmental population, if they have ever tried that, becomes really, really important and what that response was. Again, though, diphenhydramine has a high parental and practitioner acceptance. Clonidine, this is something that I included. So it's an alpha agonist. Primarily, it's been used to treat ADHD as well as blood pressure. It also has been comes out of the literature specifically for ADHD. That it actually, as you may imagine, ADHD has quite a comorbidity with insomnia. dosing clonidine at night tends to be very beneficial for improving sleep. So this is like another option, and I would say this is a particularly good option in our, again, in our neurodevelopmental cases. The same also maybe goes for guanfacine. However, guanfacine is a little bit less potent and sedating as clonidine. Again, both clonidine and guanfacine, our alpha agonists, have short-acting versions and long-acting versions. The shorter-acting versions are going to be more sedating, just because we have a higher peak and faster onset within that first hour. So typically, when we're talking about dosage of clonidine, you maybe start at 0.025. I think it's very common then to increase by 0.05 increments. And again, the things to be kind of considered of as bradycardia or hypotension, decreased consciousness. That's again in particularly high levels of dosages. Trazodone is another one that's commonly used. It's an atypical antidepressant. It's been shown to decrease sleep onset, improve sleep continuity, decreases REM, and increases slow wave sleep. So it's more restful sleep. Usually, people build up a tolerance to this, and like I said, it has antidepressant properties. So it's maybe a little bit less preferred for just sleep hygiene, and tends to have a little bit more side effects, including dizziness, cardiac arrhythmias, hypotension, and priapism. So again, there's a very narrow therapeutic index, but it might be a good option for comorbid depression. Typically, trazodone, we start at 25 milligrams to 50 milligrams. I try not to get much higher than 150, particularly in my adolescents. And then last, sometimes this is something that we see is our antipsychotics that are being used. It would be very difficult to justify using this for just insomnia. So I would recommend using an antipsychotic if there is some comorbid psychiatric issue. But generally, there's multiple things that antipsychotics target that tend to be sleep promoting, whether it's the antimuscarinic, antihistaminergic, and the serotonin. When we talk about, I just listed 4 of the atypical agents, such as clozapine, olanzapine, quetiapine, and risperidol. Risperidol and Abilify or aripiprazole are other 2 that people may be commonly aware of, but they're not very sedating. So typically, olanzapine or quetiapine are what we would use. If I'm ever using an antipsychotic for sleep, I personally would be using quetiapine for sleep, which is 25 to 50 milligrams at night. But most time, there tends to be a lot more side effects with these metabolic risks. So it's a very limited use due to that risk to benefit ratio. So in summary, kind of breaking it down from our assessment to education to pharmacotherapy, the comprehensive assessment is so crucial. Assessing for neurodevelopmental disorders, is that playing a role here? Is there sleep practices, sleep behavior, screens, that sort of thing? Is that impacting their sleep? Is there any primary sleep conditions like our sleep apnea, restless leg? And then always using that screening can be really helpful in kind of pinpointing some of these things. Then when we're getting more into the education and treatment, talking about sleep education, sleep hygiene, assessing kind of that caregiver role, like there's a parenting element that is impacting their sleep as well, particularly in our little kids. I didn't talk about this just due to time. Is there a sleep training component when we're talking about under the age of 5? And then for our older kids, CBTI. And again, just in general, what I kind of recommend for pharmacotherapy in this order is melatonin, our antihistamine such as Benadryl, and then our alpha agonists, particularly if there's a comorbid neurodevelopmental disorder. And then before trying any of those other options like trazodone or quetiapine, is really reassessing, is there a psychiatric comorbidity? And then maybe choosing something to help target more appropriately. I can send these charts out if people are interested, but this is kind of a nice consolidated of what is the starting dose, what is the titration, and then what is kind of the discontinuation protocol if there is any. And then I did include trazodone, and again, limited evidence for using TCAs like amitriptyline, doxepin, Z drugs, and then first or second generation antipsychotics. And last, I guess I maybe should have included this. This is something I added since I am on the consult service. Everything I kind of was talking about was like a little bit more general and probably outpatient, but these are some of the things to consider on the inpatient setting or hospital setting is environmental modifications, so reducing nighttime noise, dimming the lights. Some hospitals have red spectrum night lighting. Is there other things that we can do? Is there clustering activities of care, whether it's blood draws, vitals checks, or medications, doing it all at once to kind of consolidate that. Other hospitals even have no disruption policies where it's between like 10 to 6 a.m. That you're not allowed to go into the room. And then last, establishing that routine and schedule, setting a bedtime and awake time, and having light exposure. So a lot of times when I see kids, it's like at 9 o'clock and they're not up. First thing I do, I'm opening up the window and saying like, hey, we gotta get up. We gotta start getting out of the chair. We gotta do something to kind of help set and regulate that schedule. These are all of my citations. And I will stop the share if there's any questions.
Thank you. I see one request in the chat for sending the notes out, which definitely agree. I have a couple of questions that came up while we see if anyone writes anything. I know you mentioned in one of your last slides that there's no weaning off the melatonin, but you also mentioned the dose that we give is 10 plus times the physiologic level. So if we're giving it because we feel they're low on it or need it, do you find that people have a harder time getting to sleep when you initially pull it off?
Yeah, so this is kind of like an emerging like topic when we in regards to melatonin. That there seems to be some evidence that people do build up like a tolerance, so to speak, particularly when they've been on it for like a long period of time, that they're no longer creating some of that endogenous melatonin right away. So so if there's a chronic use, it might be worth tapering it off, so you do get some of the better endogenous levels. But again, that is from a literature standpoint, we still are kind of figuring that out. Typically, when we're, like I said, when we are using it as a supplement, we're really just trying to get that that hypnotic effect. There is, if we were talking about like a circadian related sleep disorder lecture, you might actually be using those smaller dosages, and you might be using it earlier in the day, which is more of that physiological level to actually reset the circadian rhythm. So I guess it gets quite complicated if you're treating something other than if you're treating a circadian related disorder.
One other question I was wondering while you were talking was, when would you use the Ramelton over melatonin? Because it seemed they were very similar, but one had over-the-counter, relatively inexpensive, and one was significantly more expensive.
Yeah, I think that's a great question. So I think when it was originally like developed, they were hoping that it would have more uh, impact on like the sleep architecture than melatonin, which would maybe justify its use. Um, and I don't think that's the that's the case that they found that. So it is kind of hard to justify it. I'll be honest. In my practice, I have very rarely seen it used, and I think I've maybe tried it once, and it was mainly something that was more patient led that they were interested in it. And then it looks like in the chat, yeah, in my training, melatonin is indicated for jet lag, not routine use thoughts. And so, yeah, I don't think there is a problem with that. And so jet lag is typically more of a, like I said, a kind of a circadian rhythm issue. So you can use melatonin to kind of like kickstart the circadian rhythm. But again, if we're really trying to treat like a circadian rhythm disorder, we want to be using more of the physiological levels, meaning that you have to end up going to like a compounding pharmacy to get that lower dosages closer to physiological levels of melatonin, because we don't really sell it over the counter at kind of that 0.1, 0.03 dosages. And then we use melatonin to regulate sleep cycle to normal after a stormy course. And yeah, and I don't think there's any, like I said, I don't think there's anything wrong using it, say after like a flight, to really kind of like jumpstart it. I know a lot of people maybe take melatonin before as a sleep aid when they get on the plane, and that tends to not impact their sleep as much either.
All right, I'm not seeing any other questions at the moment. Thank you so much. This has been a great talk, and learned quite a bit about medications that we hear and use quite frequently. Thank you.